So today I'm going to be talking to you all about a curricular paradigm that we developed at my school, University of Maryland. We developed it for the need that oftentimes medical students came out of the preclinical education. Is it echoing? Okay. They came out of the preclinical education not being totally well prepared to interview and deal with the issues faced by the LGBT community. So why should we even ask sexual orientation and gender identity data? Well, first and foremost, to have better relationships with our patients. Sexual orientation and gender identity are qualities that are intrinsic to people. And especially for people who have non-normative sexual orientations and gender identities, these are things that they've struggled with, or maybe not have struggled with, but at least at some point come to think about deeply. So it often encourages trust when we bring up these topics with our patients. It increases knowledge among the providers to learn about other people's experiences. And it also improves the delivery of care. The other big implication is that sexual and gender minority patients who aren't out to their providers are more likely to lie or to leave that provider. And these have serious health implications. And if that hasn't convinced you, then maybe the laws might. So meaningful use guidelines. These are a set of guidelines that are used to inform you on how to best use the electronic medical records, I believe, as per the Affordable Care Act. The meaningful use guidelines essentially dictate that that they want to start collecting the gender identity and sexual orientation data, I believe, by 2020. So if you haven't started asking this question to your patients, you should. Okay. Historically, people haven't disclosed their sexual orientation or gender identity, partially because it hasn't been asked, and also people haven't brought it up. But if people are out to their healthcare provider, in a certain study, they asked if you were out to your healthcare team, how did that happen? And most respondents brought it up themselves. They found it salient to their story, and they found it important to inform their provider. But much less often, what happened was that they had an opportunity to disclose it because the provider had asked them. That only happened 20% of the time. Excuse me, only 17% of the time, and on a form, 19% of the time. As you can see, that's listed in the second bullet, 45% of transgender patients have not disclosed their transgender status to their primary care physician. This was in the same study. And a quarter of all sexual and gender minority adults did not disclose their sexual practices to their doctor or healthcare provider, which for any of you in medical training, it's almost astounding to think about that because sexual history is part of the history taking, so I don't know how that wasn't disclosed. So this kind of, I guess, gap in the engagement of sexual and gender minorities with the healthcare provider results in healthcare disparities. And you can see that there are many cases of physical and mental health disparities. And to just go through a few, LGBT people who experience a prejudice-related major life event are 3 times more likely to have suffered a serious physical health problem over the next year, regardless of age, gender, employment, or even health history.
What's a prejudice-related? I have no idea what you just said. What is that?
A prejudice-related life event would be maybe being like forcibly outed. I'm talking in the context of an LGBT person. Being forcibly outed or being discriminated against for sexual orientation or gender identity. Okay. Lesbian, gay, and bisexual people who live in communities with high levels of anti-gay prejudice die 12 years earlier than peers in other communities. So you can see that this has profound effects on people's actual lives. And as for mental health, lesbian, gay, and bisexual respondents in states with protective policies, without protective policies, were 5 times more likely than those in other states to have 2 or more mental disorders. We know that the coincidence of depression, anxiety, and suicidality is very high in the LGBT community. Particularly susceptible populations are LGBT youth and transgender individuals. So it's sort of a negative feedback loop, as you can see. Healthcare system doesn't work well with LGBT populations, so LGBT populations don't come back to healthcare. And this can be seen in 2 facets: the lack of healthcare access and healthcare discrimination when interfacing, when LGBT individuals interface with the healthcare system. So in terms of access, sexual and gender minority adults are about a third more likely to lack health insurance. I believe that was a statistic from prior to the ACA full implementation in 2014. So I'm not sure what the statistic is now. Excuse me. And lesbian and bisexual women are twice as likely not to have a personal doctor, and are more likely not to be able to afford. More likely to not be able to afford medications for themselves or their families. In terms of healthcare discrimination, individuals can actually face they can face a discrimination directly when they visit the doctor, and this happens in the form of misgendering for transgender patients, or if a doctor sort of signals to the patient that they're uncomfortable with what they're hearing from the patient. And in thankfully a few number of cases, but unfortunately still a number of cases, outright refusal of care. So I think that, because physicians exhibit some degree of not being comfortable working with LGBT populations, you have to kind of go back to the root of medical school, So at medical school, do you think, it kind of begs the question, are physicians being adequately prepared to work with LGBT populations? And there's this great study from UCSF where they looked at the average number of hours dedicated to sexual and gender minority health topics, and from about, I think, 150 some schools across the country, and they found the average hours was 5, which is a very anemic number, especially when you consider how much is taught in medical school, period. So, and about 30% of schools that responded reported 0 hours. And just like Charlie had spoken about prior in the last talk, transgender patients report that they often have to inform their doctor about transgender care. And also the content that's being taught in this 5 hours dedicated to SGM topics, it's often a very public health perspective, but it doesn't kind of delve into the more personal topics such as coming out, mental health, or transitioning, or also the sociostructural barriers to healthcare faced by the SGM communities. So this kind of this whole situation is a perfect storm for making a more comprehensive effort to reform the SGM-related healthcare topics in education. My med school class, I'm up there. Okay. Now, how do medical students feel? Not good. In terms of implicit and explicit bias, we've got 80% implicit bias according to one study, and 50% explicit bias against the LGBT community, which is kind of scary. But hopefully that's changing. Oftentimes, medical students report discomfort when interviewing sexual and gender minority patients, and that often just comes with not having practiced, and also a lack of knowledge in sexual and gender minority related health topics. So to tackle these feelings that medical students have, then we really just need to like bolster the curriculum and make it more continuous throughout the preclinical and clinical years. And so that's what I'll be talking about one thing that we can do to address that. So the SOGI development model, SOGI stands for sexual orientation and gender identity. This is one model that I helped introduce at my school that we are going to be putting into our preclinical medical education, which basically talks about the process of changing an identity that you've intrinsically valued, as X into Y, over your whole life. So essentially, they're categorical phases of the lived experience of sexual minority persons. So in essence, if you think that individuals start, being socialized to believe that they're heterosexual individuals, and then over time, maybe right before puberty or so, they start realizing that they're actually somewhere on the spectrum. This model describes the process of coming to terms with that. I took this from the actual paper. It can describe the existential position of patients with regards to sexual orientation or gender identity. It's difficult to describe an existential position, as any of you could probably surmise at any moment, but that's what this model aims to do. And it standardizes the idea that non-normative gender and sexual orientation development is an experiential process. It is a journey. It is a gender journey. It is a sexual orientation journey. Informing medical students of that is incredibly important for them to build empathy and also to understand the stories and narratives of LGBT patients. It's already actually being used in counseling and psychology settings, so let's get medicine up to speed. All right, so the model is actually 6 phases, but at my school we adapted it to 3. The first phase is questioning and experimentation. The second is identity tolerance. And the third is identity acceptance and synthesis. And I put it in this cycle because people go forward and backward in this between these phases, and it's a very nonlinear path because that's exactly what journeys are. Okay. So advantages to using the development model to treat these patients. Practitioners will be informed of the thoughts, feelings, and experiences patients may feel. Obviously, you can't assume what anybody is going through, but being cognizant that, maybe this, kind of contentious part of their life is informing how they're behaving or what their choices might be is really important. It helps us stratify some of the physical and mental health needs of the patient. And above all, it establishes trust and rapport and builds communication between you and your patient if you know what they're going through. Okay, phase 1, questioning and experimentation. So a sexual and gender minority individual experiences feelings incongruent with their currently accepted SOGI. At this time, they may be seeking information or experimenting with practices to explore non-normative SOGI. I put this picture up because this is the point where a lot of people start looking for labels, and they identify with one of these letters, or they might switch around with the letters, or identify with multiple letters. This is a place where things are extremely fluid for people, and this is also a phase for an LGBT person where they might not actually, they're not even willing to talk about it outside of themselves. So it's important to know. Okay, clinical implications. So potential mental health susceptibilities at this phase might be feelings of confusion or guilt within the patient. They might be prone to anxiety or depression as a result of these feelings. Gender dysphoria is usually this phase. Also, the other caveat that I should have mentioned in the beginning is these phases can overlap. Pretend like it's one giant messy Venn diagram, and you could be anywhere, a patient could be anywhere on it. All right. So examples of physical health susceptibilities would be engaging in risky sexual or non-sexual behavior without proper education or in secret. Self-harm, bullying, binding practices, basically like anything that they might have, patients might find on the internet that they might think, this might help me feel better about myself. It may or may not. Oftentimes, patients might approach you with information that you say, hold up, let's research that and let's see if that's actually safe to do. Yeah. Moving on, identity tolerance. This is a temporary acceptance of your identity, your sexual orientation, or your gender identity. And individuals start to establish and define their boundaries, and they seek a community. They seek role models. They seek friends. And this is the place where people start to come out to families, communities, and providers. Okay, so coming out. This is an extremely important thing because as a provider, you are essentially going to be like a proxy family member. Coming out is not something that most people like to do. It's something that often they feel that they have to do. And especially for providers, to sit there and be as non-judgmental as possible is an extremely important quality that we should maintain when interfacing with LGBT populations. So patients seek non-judgmental acceptance, respect, openness, kindness. And this is important because we want to retain our patients, not just have a good, trusting relationship with them, but we want to keep them. And they're more likely to stay with us if we have a positive and accepting and affirming response to them coming out to us. Okay. The clinical applications are actually similar, and this is actually a phase of the model that I would love some collaboration on in terms of like filling out, because at my school this is actually one of the limitations that we have in terms of implementing it. A lot of these applications with mental and physical susceptibilities are similar between the phases. But anyway, the big differences are because coming out is a more interpersonal part of somebody's life, or it's a more interpersonal process, there's a possibility for interpersonal conflict. So that's the bigger mental and physical health susceptibilities. And the last is identity synthesis. And I have the great George Takei here for the most proudly gay person that I've ever seen on camera. Anyway, so this is permanent acceptance of the SOGI to the point that it's just literally just a part of their life, just like the color of their hair or the color of their eyes. And this is the part of somebody's life where they're essentially kind of over it, and you shouldn't make it a big deal either. In terms of clinical applications, bigger things are essentially things like family counseling, but you should also understand that systemic oppressive forces are still existing, so they are still prone to structural discrimination. So those are always important and salient features to any queer person's life. Sorry. Okay. In preclinical education, it would be important to integrate this into clinical case examples and learning terminology around how to identify where somebody is on this on the spectrum. And finally, like safety assessment. Safety is a huge issue for LGBT patients at any phase in their life or any phase of their sexual orientation or gender identity. In clinical education, we're just moving it from, maybe case reports to like standardized patients or actual patients. For anybody involved in medical education, give the students difficult cases. Give them the suicidal patient. Give them the transitioning patient. Give them the person who got kicked out for being gay. Give them those patients because we need them to practice with, because when an actual patient comes to us, we want to be able to help them the most, like as best possible, excuse me. Okay, and limitations, there's obviously a lot of gender differences trans men versus trans women, lesbians versus gay men. There's a lot of intersections with this model and also gender. So a lot of these things need to sort of be filled out over time. There's also a range of these sexual orientation, gender identity, status outcomes, meaning that don't expect everyone to end up in phase 3. You know, people can be anywhere, and it's okay to be anywhere. You know. So in acknowledgement, I just want to thank my school. Hey guys, hey mom. To the clinical medicine course that I worked with to help develop this, and our and also Medicine Exed. And thank you all for being such a great audience.